I'm excited now to introduce our next speaker. Dr. Daniel Hairston, MD, is a double board certified adult consultation liaison psychiatrist, medical educator, author, speaker, and promoter of mental wellness. Dr. Daniel Hairston was raised in the Washington, D.C. metro area. She attended Rutgers University for her undergraduate education and earned a degree in biological sciences. She earned her medical degree at Howard University College of Medicine. She was chief resident for the Department of Psychiatry at Howard University Hospital, where she completed her general psychiatry residency. She completed her consultation liaison psychiatry fellowship and went on to become faculty at the University of Maryland School of Medicine, Department of Psychiatry in Baltimore. 2018, Dr. Hairston returned to Howard University College of Medicine as an assistant professor and was recently appointed as the Psychiatry Residency Program Director. Dr. Hairston currently serves as the American Psychiatric Association's Black Caucus President, and she has served as the Black Psychiatrists of America Scientific Program Chair since 2016. Dr. Hairston has spoken nationally and internationally about the impact of race and culture on mental health. She's a contributing author to the recently published book, Racism and Psychiatry, Contemporary Issues and Interventions, and her interests include consultation liaison psychiatry, resident education, underrepresented minorities in medicine, faith and mental health, and health and racism. And so I am so delighted to hand it over to Dr. Hairston. Take it away. Thank you.
Okay, thank you. Thank you, Wendy. I have got to work on making that bio a little bit shorter. All right. So I'm excited and honored and privileged to be here, especially to be following Dr. Cogburn. I was just in awe, and I was like, oh, I got to get my slides together. I'm not even ready for this yet. All right. So I am Danielle Hairston. I am all of the things. I have nothing to disclose financially except for Howard University is the institution that pays me. And as Wendy mentioned, I am an author on a book that I will be discussing, but not promoting. These are our goals. We will really just get into it. I hope that this is more of a conversation. I'm going to give you the information. We're going to digest it and discuss it together. We're going to identify some strategies. I'm not going to really identify all the strategies for you. That's why we're having this whole workshop, but I'm going to give you some ideas and some basis and foundation for what you can build upon. And the most important thing I think that we're really going to do here is deconstruct the social determinants of health contributing to health disparities in, I'm saying BIPOC, but really we're going to work on centering Black communities here today. All right, so let's talk about really just the disparities in mental health at this time. So Dr. Cogburn really talked to us about the difference between disparities, which is differences, and inequities, which is something that's more actionable. But what we do know is that 1 in 3 Black Americans who need mental health care receives it. So that's only 1 in 3. So the rest of them are not likely to receive mental health care. Compared to whites, Black Americans are less likely to do all of these things, receive evidence-based care, consistent care, receive care from mental health specialists. They usually receive care in other places. They're less likely to be included in research, as Dr. Cogburn let us know, and also they are less likely to be offered therapy as a treatment option, and also medications as well. So I'm just going to show this video that's going to just describe a little bit further the current state of mental health in America. So hopefully we practice this and we'll be able to hear.
It's about the access to the care and how we are taking care of it. And that's where the African American community is falling behind when it comes to treatment, when it comes to access, and when it comes to stigma about obtaining mental health care.
Both culturally and nationally, there has been very little attention on it. There are reasons, I believe, for that related to discrimination against African Americans, so that there is a need for consciousness raising within the community and for much more focus from the professional mental health community.
We need help just like everyone else does. And everyone who helps can't look like me just based on the sheer numbers, right? There just aren't enough psychiatrists. So understand where your patients are coming from. Understand that if a patient is late for an appointment, understand how many buses it took for them to get there. If they don't have the money for a medication, understand that they might have had to choose between filling a medication or getting some snacks for their kids. Understand that they might not even have access to a grocery store. Understand how long it took for them to get here. Understand that they also have high blood pressure and they're standing outside waiting for the bus in 100 degrees. So really just a better understanding and a better appreciation for your patient's experience as a human being.
I know people who go say that they're going to see the person for their allergies when they're really going to see their therapist. So it's not something that we're comfortable with because we don't believe in, so many of us don't believe in talking about our problems or airing your dirty laundry.
So there's distance to go on the professional level, and there's some distance to go within the community itself.
Why aren't you offering the same treatment to a black patient who comes in the ER? Why are you just offering them inpatient admission and restraints and high doses of antipsychotics? Why aren't they offered an outpatient regular follow-up? Why aren't they offered an intensive outpatient program? Why aren't they offered medications? Oh, because you heard that black people don't take medications? That's what I'm talking about with like cultural competency, why we need to move away from that and understand why someone might not want to take a medication, why someone might not be trustworthy, might not be trusting a physician. There's a whole thing called the Tuskegee experiment. Know that these people who went through that and people whose family members, they're still alive. They remember these things. So why you need to take that extra step with these patients and let them know, like, I'm here to help you. I'm trying to do this, and show some compassion. So show some empathy and really equal treatment.
All right, so I figured I'd show the video with some other leaders in this mental health world and in policies and education so that we can see that this is something that cannot be just covered by psychiatrists. It cannot be just covered by psychologists and mental health providers. The things that we need are systemic and are needed at a societal and institutional level. And where have we seen this year, unlike any other time that we can really note recently? Is with COVID-19. So COVID-19 has shown us what many of us have already known in the mental health field and medicine, but I guess people turn a blind eye to or just weren't aware of, which is that there's a racial disparity and there's implicit bias in medicine and psychiatry specifically. So what we're really going to talk about and think about, I want you to really consider that it's not race that is a social determinant of health. The pandemic has showed us that. It's racism. And I think Dr. Cogburn showed us that and taught us that. And I'm really just going to back her up and expound upon that just a little bit more. But when you're looking at patients, when we're thinking about patients, and when you're thinking about what to do in the AI and the virtual reality community and space for how to help people with mental health issues who come from Black communities, think about these things. Think about a lack of providers from diverse and racial ethnic backgrounds. Think about a lack of housing. And that's something that I really care about. I'm going to talk about and address later. But think about food security. How can you ask someone to stick to a diet and do this and they don't even have access to food or a grocery store? Think about employment. Think about transportation. Think about how neighborhoods are built and where hospitals are. Think about a mistrust of the healthcare system. So sometimes people say there's a paranoia. I think it's just an actual healthy mistrust of a healthcare system that has oppressed your people and your family members for so long, for generations. Think about underinsurance and think about stigma and think about where the stigma came from. So all racism is not overt. As Dr. Cogburn said, we hear a lot of times people say, "Oh, I'm not racist. Like, I don't think that people should burn crosses. I don't march with the KKK. I'm not a Proud Boy. Like, I'm not racist." And to that, we have to say that all racism is not overt. There's literally levels to this. And you'll hear me say and others say systemic racism, institutional racism, structural racism. Those are all used interchangeably. So those are things that are really embedded in the fibers of our culture and our society. Interpersonal racism is something that people are able to see a little bit more. They see, someone does something, a hateful act towards someone else, or uses a racial slur. People are able to understand that interpersonal racism. And then internalized racism, which is really the one that is the most difficult for me to really navigate and just really work with patients and colleagues. Internalized racism is when you start to believe these racist things that are stated about you, and you start to participate in the perpetuation of these racist statements and of the stigma and prejudices that are in our society. So again, systemic racism is a system in which public policies, so that's government, institutional practices, cultural representations, other norms work in various ways to reinforce and perpetuate racial group inequity or white supremacy, as we heard about earlier this morning. It identifies dimensions of our history and culture that have allowed privileges associated with whiteness and disadvantages associated with color, or specifically Blackness, to endure and adapt over time. So I encourage you, the Aspen Institute has some great definitions. I believe they have like 11 that you should know. You should know them. So again, all racism is not overt. I'm not racist is actually not an acceptable statement at this time. So let's look at some ways that racism manifests. Racism is explicit hate, yes, but it's more than just that one manifestation. So one manifestation of racism, systemic or institutional, is denying that racism even exists. It's asking an oppressed people, are you sure that was racist? Or saying, oh, I don't think that was racist. Or my favorite in academics and research is, do you have any data on that? Unacceptable. This is called gaslighting. Another way that racism manifests in a system is denying home loans to Black people from certain neighborhoods. This is limiting potential for building economic wealth. And this is also a policy called redlining, which I will get into later. But you are denying people the ability to be a part of the greatest wealth building system in this country, which is home ownership. And weaponization of privilege. That's calling the police to report Black people for living their lives. This includes eating, sleeping, sitting, jogging, and even recently, bird watching. So other ways that we see racism in a systemic way is sentencing disparities. Many of you may not be aware, but it's true. There's a sentencing difference for offenses for people who have possession of crack versus powder cocaine. And you know that we see crack cocaine more prevalently used in lower socioeconomic and Black communities versus powder cocaine, which is more of a drug for white people. And we see the disparities in sentencing for that. It's a systemic policy. As Dr. Cogburn alluded to, you would think that we did our slides together, right? As Dr. Cogburn alluded to earlier with her VR program, there's also refusing to hire and promote Black employees and using coded language like they aren't the right fit when the feelings are really truly about a person's race. And then, of course, back to my field, providing biased healthcare. So that's treating BIPOC or specifically Black patients and white patients with the same symptoms and concerns differently. And this is something that we see frequently. We see this in trauma, we see this in depression and mood disorders, and we specifically, really the most data, we see this in schizophrenia and other psychotic disorders. So keep this in mind. We're gonna try to talk about it. It's gonna be a little talking about it, or you're gonna try to type about it so that we can just consider, and you can put these in the chat or in the Q&A, just other ways that we see racism manifest that is not just in the overt, oh, I'm not racist way. Bias is another term that I think that we should highlight here. So a lot of times we talk about implicit bias, and I think we have to really be careful with using bias, which is a preference, or it may be favorable, it may be unfavorable, but really saying implicit or unconscious bias, that really implies that people have there's nothing that they can do to change this. It's just something that's automatic. And we really have to really dissect and think about this when we are discussing these biases. So explicit racial bias, these are things that people can really get behind and say like, oh, yes, I think that that's wrong. I see that that's wrong. So it's conscious. This would be like a clinician or a doctor who acknowledges that they have a preference or aversion for a certain racial or ethnic group. And it can be suppressed or acted upon due to societal norms. That's why institutions and systems are important, because they really inform what is acceptable. So they can lead to racist acts that are purposeful. Now, these are examples that people can say, and these are from the book. These are examples that people can say, oh, yes, I can identify that that is not correct. So a physician who refuses to provide care to Black patients, or a white patient who refuses to see a Black physician. People can say, yes, that's racist. I understand that. Physicians who join anti-immigrant rallies protesting providing clinical care to Latinx immigrants. Okay, people can say that they understand that that is not right. That's explicit. Now, implicit, that's a little bit different. So these are unconscious associations of stereotypical attributes with particular racial groups. And again, these negative associations are really informed by the culture, by the society, and by the norms that the institutions perpetuate. And you see these more in stress, high pace, fast pace, high emotionally toned situations. So an example, you can read this example, but I'm just going to just describe it briefly because this is a real life example. So a physician whose neighbor was robbed by a Black male one day prior to her working on an inpatient psychiatric unit. The physician is not aware that she has any bias. She watches the nightly news, as Dr. Cogburn told us about. She might see news bulletins about Black males being aggressive, being violent. She sees that in her everyday. During a shift, an acutely agitated Black male is having a psychiatric or mental health crisis. The patient was initially threatening or seen posturing, but he was able to be de-escalated and calmed down from staff. So it was finished. However, the physician, feeling threatened, saying that she feels this patient is aggressive, insists that the patient should be restrained to manage potential aggression and started on a high dose antipsychotic despite the patient's calm state and lack of consensus amongst the staffs. So that's an example of a bias that we see perpetuated very frequently. The use of high dose antipsychotics for Black males is something that has been studied across time in psychiatry and mental health. But let me just tell you about some other biases that there are in medicine as well. A really pivotal research article in cardiology was from 1999. Schulman and his group found that MI treatment recommendations, that's cardiovascular, that's a heart attack recommendations, changed based on a patient's race and gender. So they had patients who they had the exact same symptoms. They were standardized patients, same symptoms, same clinical picture. And all the time, there was just a disparity seen in the treatment that was provided to Black patients. Black women in particular were less likely to have their symptoms paid attention to, and they were less likely to be referred to cardiac cath lab, which is the next step in treatment for a heart attack or a myocardial infarction. So same exact clinical picture. All they did was change the race of the patient, and Black women were least likely to be referred to for treatment. Often another one in Virginia, this was big in medicine about 4 years ago, was from the Hoffman Group, where physicians and medical students said that they literally felt that Black people experienced pain differently than white people, and that Black people had different nerve endings and did not need to be given the same amount of pain medication as their white counterparts. So this is real, and this is something that happened in 2016 with the millennials, currently happening right now, around the time that I was in residency. This is a big thing that came out. And also, I just chose one. There are several studies. There's a lot of research that shows the disparities and the overdiagnosis of schizophrenia and psychotic disorders. Strowski from 2003 is an example. And in this study, again, psychiatrists were given the same exact clinical picture, same exact clinical presentation. The only thing that was changed was the race of the patients, and overwhelmingly African American and Black patients were diagnosed with schizophrenia or a psychotic disorder, and white patients were diagnosed with a mood disorder like depression or bipolar disorder, even though they were presenting with the exact same symptoms. So this is something that we see across the board. We also see this in treatment for substance use disorders. This is just from 2019. Buprenorphine is a treatment. It's a medication treatment to help with opioid use disorder. And it's actually just become known really as marketed towards and used for white persons who have private insurance or use self-pay. They looked at groups of people. Again, Black people were not offered this treatment, and they were especially not offered this treatment if they were on Medicaid or Medicare. And this was overwhelmingly, there was seen a disparity of offering this treatment only to white persons who have private pay or self-pay. So individuals are a part of a system, and I'm going to come back to this a couple times, but we are trained and educated, especially in medicine and just as a society as a whole, to care for or focus on an individual people. But we should really understand how systemic racism affects people. These are the disparities that I discussed with you earlier. And the one that I really want you to think about and consider here, just one, we talked about racism, but I'm really going to talk to you about housing. So I'm actually going to turn off my camera because I want you to actually look at this map while I'm talking. You guys are Pacific, most of you, so I went with a California city, but these maps are available. These maps are available across the, hold on, let me go back, across the country. So, yes, let's go. All right, so this is an example of a redlining map from San Jose in California. So you know that I am a psychiatrist, I'm an MD, a physician. I am not a historian, but this is something that I actually care about and like to investigate. And I really think it's important for me to understand, and you also to understand, when we consider all the things that impact someone's mental health. So in the 1930s, a federal agency, the Homeowners Loan Corporation, HOLC for short, created residential security maps. These were called security maps for major American cities. Red areas were deemed hazardous, and there was a systemic denial of loans for home ownership in these areas. So this is called redlining, and it's actually predatory lending, and it created insular neighborhoods, which people now refer to and then as ghettos. So the US government and the Supreme Court says that education can be funded at a local level from taxes, which are again informed by these neighborhoods and how much money housing creates. So it also determines and impacts medical systems and where they are placed. So these redlining maps have led to medical deserts. They've led to food deserts. They've led to places where there is little or no transportation, and patients and people can feel trapped here. So they're continuing to perpetuate these insular neighborhoods. But this is also where many patients and families have their social networks. And again, this is how a systemic problem is framed as an individual problem. All right, I'm back. So we are not without history. It's important to understand the experiences, risk, and trauma of your patients. Well, not your patients, but the people that you're creating things for. Clinicians who focus on treating solely the presenting symptoms without giving consideration to the socioeconomic, the political, the historical context are destined to be inadequate, and that's just what it is. Intergenerational trauma is suffered by one generation to the next, be it individual or collective, and passed on to future generations. So Dr. Cogburn really alluded to how trauma affects a person, but you have to understand also how trauma is passed throughout Black and BIPOC, but we're centering on Blackness today. Understand how intergenerational trauma is defined as the transmission of historical oppression and its negative consequences across generations. And you see this especially in the way that people access care. So as we think about individuals who have these symptoms and have these issues in mental health, we really have to think about how individuals, again, are you seeing a theme here? Individuals are a part of a system. And we have to think about using words like compliance, and instead of compliance, really understanding the social determinants of health, which is the nice and palatable way of saying systemic racism. We have to think about interdisciplinary treatment planning and collaborative care and treatment goals in mental health. So that means, what do my patients need in order to work with the treatment goals that we have set? Do they need assistance with getting to these appointments? Do they need assistance with food? Do they need assistance with how to approach talking to and advocating for themselves with different physicians and physician groups? So these are clinical implications, and I put these things in parentheses so that you can really think about how they are important and how they play out in your field. So clinicians, or you, can make the invisible visible. So this is where I really want to talk about color blindness, which I feel is extremely harmful to patients and just people in general. Because if you say that you don't see color and that you look at everyone the same, you are ignoring a key portion to their identity and their experience and the experience of their families. Healthcare organizations can engage the community in an effort to change the accepted explanatory narrative or the accepted cultural norms. So this is where we have to really make changes. Organizations, systems, right? Individuals are a part of a system. Institutions can make systemic changes to eliminate structural racism. I'm using eliminate here. I'm being adventurous by saying eliminate, but we can at least make changes, or systems can at least make changes to mitigate structural racism and its impact. Okay, obviously I really liked that slide. All right, this is the time that I really want to talk about what you're going to be. You have to decide what's your role going to be. Are you going to be an ally? Are you going to be a sponsor? Or are you going to be an advocate? And they're all different. So an ally, are you going to be someone who says, I support Black Lives Matter? Look at this. I posted the black square on this blackout day. I have a Black Lives Matter sign on my window, on my lawn. Look at me. That's what I'm doing. This is how I'm going to be an ally. I'm going to support, and I'm going to call and check on all the Black people that I know and let them know that I support them. Okay, thank you for that. But we need to move away from being an ally, and we really need to consider being a sponsor and being an advocate. And a sponsor is someone who uses their privilege, uses their resources, uses their strategies, uses their involvement in these systems and leadership to make changes. This is where you put literally your funds and your resources behind what you're saying. And are you going to actually advocate? When you see something that's incorrect, are you going to say something about it? Are you going to do something? So you can be an ally, you can be a sponsor, you can be an advocate, or you really have to decide, or are you going to be a colonizer? Are you going to actually make a difference? Are you going to avoid performative allyship? And when I say, are you going to be a colonizer, I want to really give a good example of how VR and AI impact the medical field here. So a couple months ago, we saw that New York's Icahn School of Medicine at Mount Sinai used Zoom filters that could change the faces and voices of patients to simulate diverse sets of patients. Instead of actually hiring patient actors or trainers who are from diverse backgrounds, this medical school created filters to simulate Black and Latinx faces and voices. And I'm wondering, what did the Black voice sound like exactly? Like, because we are not a monolith. So whose idea was this, that you should use your VR skills, your AI skills to make Zoom filters to help supposedly promote diversity in patient care, but instead you're actually being a colonizer and harming the patients and the students that you are trying to train. So again, are you going to be an ally, a sponsor, an advocate, or a colonizer? Especially for all of you in the VR world. It's going to take more than a performative allyship. It's going to take more than a post. It's going to take a whole entire culture shift to mitigate these disparities. All right, so how can you reduce and eliminate your own biases? I'd really love for you to come up with these ideas yourself, and you can talk to me about it in the chat and the Q&A. But the first, let me just give you some basics here. Well, obviously, don't be involved in blackface like we saw in the previous slide. Don't do that. But also ask uncomfortable questions. And these questions are for yourself, and these questions are for your team. When something happens that you see is, you think it might be a part of systemic racism, you think it might be, you might be perpetuating a disparity, you think something like that, say something. Ask your team, well, why are we doing that? So this is something that I have to do in my practice. And simply, I can say it as nicely and as palatable as possible. When I see a Black patient who's receiving high doses of antipsychotics and being put in restraints and not being offered voluntary treatment, I say, oh, why are we giving this patient that? Like, that's all I say is to my colleagues in the emergency department when they call me down for a consult and tell me, oh, we had to give them this and this and this and this and this. And I'm like, why are we doing that? And simply just that question about why are we doing this makes someone have to actually think. They might stumble, but it has to make them actually consider why they're taking these steps in the treatment. And really, we have to think about standards of care. Is this the same care that you would be providing for someone, whether they were Black, white, Latinx, if they were your mother? This is, again, for the white liberal choir. Is this something that that would be acceptable for someone in your family? And also another thing here is centering. Centering anti-Black racism is important. This is not the time. And I don't know when is the time, but this is not the time, and we're not really interested in oppression Olympics. Like, this is not the time to say, oh, well, what about me, and try to shift the conversation, because again, that's invalidating. And if you go back to the first slide that I said, some examples of racism's other manifestations, gaslighting and invalidation. So to say, oh, well, are we going to be talking, what about women? Or, oh, well, we receive discrimination too. Like, again, this is not the time for oppression Olympics. This is the time where we have to center on issues for Black people. Black people, this is not new to us. Across the diaspora, we have been experiencing this oppression, this generational trauma for over 400 years. I think it's about I think it's appropriate that we can center on anti-Black racism at this time. So I'm very into action, and coming up with strategies, resources, and involvement. Now, first, decide how are you going to accomplish these things? Advocate. You can do outreach. These communities, these Black people, these Black families have been traumatized for generations from all systems. We saw how they've been affected by housing. We see how they're affected by medicine. So you know what? It's the time for these systems, these leaders, these people who've written their statements of solidarity. Remember those earlier in the pandemic, statements of solidarity? Yeah, it's time for them to actually do some outreach, actually reach out to these communities, provide education, and first of all, really show some acknowledgement and validate that these are the experiences of Black people in this country, whether it's in the system of housing, whether it's in the system of medicine, whether it's in the system of education. All right, so if you want to find me, you can definitely find me here. You can tweet me. I have a little platform called @BlackPsychiatry. You can tweet me. We can have any type of conversation, but if you cuss at me, I'm blocking you. So I added this bonus slide here because I usually don't. I've been known to say that when Black people go through trauma and oppression, and when a Black person is killed, we have our trauma, and Black and white people want to have a book club. So I usually actually don't put these up here, but this is a book club slide for you. So if you are actually invested and you care about making a difference, then you need to have the education. So Racism in Psychiatry is a book that I am a co-author of, and I specifically talk about how to change the way that we assess and diagnose patients with mental health issues, schizophrenia, trauma, neglect. There's also an overdiagnosis of Black children with ADHD and misses frequently mood disorders, anxiety, and trauma. The Process Psychosis by Jonathan Metzl. He's white, but it's still a good book. He talks about the history about how schizophrenia became a Black disease. And then one of my all-time favorite books is Why Are All the Black Kids Sitting Together in the Cafeteria? And this is a book that really helps you to understand all of the psychosocial impact of the way that we're socialized in this country to understand racism and how it plays out and manifests clinically and just in general in our society. All right, so that's it for my presentation, that's it for my slides.
Thank you so very much, Dr. Harrison. That was dope. And I'm just so impressed with your ability to weave psychiatry and public health and structural racism and history and advocacy into one 30-minute talk. So that's extremely impressive. So thank you so much for your time. Okay. I want to encourage folks to add questions in the Q&A, but I would love to kick us off. And as you're talking, one of the things that kept coming up for me is that how do we get to joy? And so we are now raising an awareness of the interlocking structural, individual, and community level issues as it relates to racism and mental health. White folks are now in book clubs and forming groups to talk about these issues. And yet, Black folks still need liberation and still need to work on their mental health. And so how do we leverage these conversations in what we know from psychiatry and public health towards helping patients and community members towards joy? What are your thoughts about that?
Well, let me say first, that's probably the fastest I've ever done that presentation ever. So I was trying to really jam everything that we need to know at a superficial, without going into too much depth level. So first of all, how do we have some joy? So one thing that I am, as Dr. Cogburn said, I'm happy to check the black box. I am excited and I'm happy to be a part of this culture, because when I see videos of people dancing at the polls, waiting in line for hours and hours and doing the wobble, but they are out here just having joy and bringing joy and happiness, collective happiness. I think that that's what's important about our culture. So we really have to work on understanding and remembering who we are outside of this pandemic, who we are outside of this racial and social injustice, and who we are and what brings us together and what has brought us through thus far. And whether that's Black girl magic, whether that's Black boy joy. I don't know if I like Black boy joy, but whichever one it is, remembering who you are. You have to remember who you are. And then really for me, that I try to tell everyone and I try to really accept for myself is, one, allowing yourself some grace. Really understanding, really understanding that this is not easy. This is not easy. This is weighing on all of us. This is weighing on every single person. This is weighing on you, Desmond. This is weighing on Dr. Courtney as well. This is weighing on me. And allow yourself some grace. This is heavy stuff. This is heavy lifting. And this is something that we all have been experiencing. As I said, it's a collective trauma. It's generational trauma. It's been going on for so long. So allow yourself some grace and also have some boundaries. Now that's boundaries is probably my thing that I preach about the most, because I need to accept it myself. But really saying I'm not able to do that. I am not going to put I'm not going to take on all of the weight of this system as the one Black person in my group, as the one Black person in this work group. I'm not going to be the one who does all the tasks. I'm not doing this. And really, systems and institutions, companies, corporate, whatever it is, really has to understand that you have to invest in this. That's what I was talking about, being a sponsor. Like, if you actually care about this, you don't ask your other faculty member or the other person in your group, oh, can you just run this group for me so we can check off a box? We're not checking off boxes. You invest in this. I guess like what Microsoft is doing. You invest in this. You find the leaders in this, you sponsor them, you fund them, and you make this happen. You don't just say, oh, okay, you're Black in my group. You can do this, right? You're a lead. You've been Black. All right, I guess you can do this. Check and on to the next thing. So the way that we have some joy is by remembering who we are, allowing ourselves some grace, and also setting up boundaries in all spaces, homework.
Wonderful. Thank you so much. That's very helpful. Another issue that I oftentimes see when I interface with folks in artificial intelligence and data science is that there's a quickness to want to provide a tech solution to the problem, even a problem that they know very little about. And in particular, this case would be mental health. And so I guess if you were to have conversations with data scientists or AI researchers that want to do work in mental health, how would you help them to understand the problem?
I think, again, this is a place where there are literally experts. And I think that this is something when Wendy told me about how they put out the call for, funding for research. And she's like, and then we didn't get any responses. I was like, oh, I never saw that. Like, I've never seen that. I've never heard anyone, any of my circles or networks talk about this. So this is where you need to actually, as I said, do something, do some outreach, do something to reach out to the leaders in this field, reach out to the people who actually do this. You know what I do when I don't know someone in some field? Like when I was trying to find someone who could help me with like app things, I went on Twitter and I was like, hashtag Blacks in Tech. And then that's how I found people. Like, you have to actually take some initiative and actually do that. Like, I don't know if it's a stretch, but you have to actually reach out to the people who do this work every single day. And that person does not have to be necessarily someone in a academic institution. Of course, shout out to the one that pays me, Howard University, but and who connected me with Wendy and the Microsoft group. But actually take some initiative. You are creative, you're resourceful, you're knowledgeable in every other realm of life. But this one, you're just puzzled, you don't know what to do. That's not acceptable. You really have to now reach out to these groups. Reach out to Howard. Reach out. Do you know all the Black excellence that comes from HBCUs in this country, especially in medicine? Reach out to them and say, is there anyone we should talk to? If you want to know about mental health, find the Black people who work in the American Psychiatric Association who do that work, like me, in the American Psychological Association, in the Black Psychiatrists of America, the Black social workers. Reach out to these groups, like they exist. Yes, we're unicorns. Yes, we are wonderful. We are excellent, but we're here. And put your resources, your money, your time, your efforts behind these statements of solidarity.
Wendy, do you have more questions?
Oh, yeah, I'm going to have a ton more questions, and I'm really glad to now have these connections with folks. And so, yes, this is it's a good journey for us, and so I'm excited that we're having this discussion today. I think the thing I wanted to come back to, and thank you for an excellent talk, Dr. Hairston, is, given this long history of racism and research, are all those studies being recreated with more diverse populations by Black researchers? Like, how do we then create this new sense, this new knowledge that is needed so that we aren't creating these overdiagnoses and that we're great, that there are more fair diagnoses? I mean, I think part of what I heard you say is having more Black practitioners is the way to go, but there's just been so much research that all that's based on. So how do we remedy that?
Okay, there are definitely layers to that question, Wendy, but let me say that, so having more Black psychiatrists or Black researchers or Black psychologists or social workers, that's not going to fix this problem, because there just aren't enough of us. So having more is going to be helpful, but again, it's coming from the top. Like, who do you sponsor and who do you fund? And we have seen from NIH, the drug abuse, the mental health components of NIH, we saw numbers that came out and told us that Black people are less likely to be funded. And when you submit a proposal for a grant, they say, oh, well, are you sure that this diversity really matters in this way? And you get rejected. And that is what really needs to change. Not that, oh, we need more of us, because when there are more of us who are frequently and consistently getting shut down, and you frequently submit proposals and then you're told that, oh, we're going to go in a different direction, or this wasn't the right fit, or racism was mentioned too many times in your proposal. That's a personal one that I can give you. We need to change these systems. We need to change the higher ups who are deciding this, because it's frequently sending, again, like just another form of oppression, that when I write these papers, when Dr. Desmond writes these papers, when Dr. Courtney Cogburn writes these papers, and then they are rejected by these academic journals because they're like, well, we don't really know if that's important, or that's not the direction that we want to go in. Oh, we appreciate you bringing up this diversity. However, we're going to pick another paper written by someone who's lacking in melanin. So, it's important that we change how the systems are. So yes, it's great for us to have more people, but it's really about accepting. I don't know what happened with my lighting. It's really about accepting the proposals, accepting the projects, funding these projects, funding the researchers who are submitting these things to you every single year, every month, working on this literally, because the minority tax that people experience in academics and in research, it's taxing, like it's taking a toll. So really support us, support these efforts, and put the funds behind your, I keep saying that, I have things though, put the funds behind your solidarity statements.
Okay. Yes, that makes a lot of sense. And as someone in a program, I am excited for us to actively fund more projects. And then, yes, thank you. That's a really powerful answer. We have about 3 minutes left. And so I want to thank you again, Dr. Hairston. I want to thank Dr. Cogburn. Thank you, Desmond, for helping with the moderating. I want to kind of talk to what's happening next. So I want to remind folks that we have a break from, in the Pacific Coast, it's 11 to 11:30, so just a 30-minute break right now. And then we will reconvene in our breakout groups. So everyone should have received an invite for the group that you were assigned to. The assignments, we tried to give you the groups you voted for. There was one group that was more popular than the others, so we did divide people. But we're really looking forward to continuing this conversation. And our goal is that we will be creating a report, all of us together creating a report that we will release publicly after the event. And the report is to help amplify what we've learned, amplify Black voices, help share what we've learned, and not only help with funding decisions by our program, but to what Dr. Hairston was just saying, can we help influence other programs as well? Dunno, I'd love to try. I also want to highlight that tomorrow we have our networking mixer, and so thank you. I see the slide just went up. This is going to be led by Heather, and we're going to try and have some fun. Try and find some joy, as we were just talking about. And then we come back on Thursday, starting again at 9 a.m. Pacific. We have 2 more hours. Today we had 2 hours. We have 2 more hours on Thursday with 3 more absolutely fascinating and awesome speakers. I'm very excited for you to hear. And then again, Thursday afternoon, we will break out into our small groups. And so today we'll be focusing on defining the problem for our small groups. On Thursday, the small groups will be looking at solutions and next steps and recommendations for what happens next. And with that, we're going to give you 30 minutes, but come back to Teams, get into your groups, and let's have a really awesome discussion this afternoon. So again, thank you all. Desmond, anything you want to say before we head off on break?
No, have a good break.
All right, everybody. Enjoy the break, and we'll see you in 30 minutes. Thank you all so much.